Need an answer to a medical question? Join us for our viewers' favorite show, which provides our audience the chance to have their medical questions answered by our Prairie Doc and guests. Ask Anything, tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Jill Kruse, and tonight we will be hosting one of our viewers' favorite shows, Ask Anything. This week, Prairie Doc was set to host an episode about AI and technology in medicine with Dr. Tony Olivia. Dr. Olivia currently resides in Florida and has been affected by Hurricane Milton. Our thoughts are with all of Florida and other states that have been devastated by the hurricane season this year. If you would like to support those affected, please contact the Red Cross. Tonight, we will be taking viewer questions about any medical topic. Thank you for joining us this evening. This evening, we are joined in studio by Dr. Kenric Malmberg from Avera Medical Group Brookings and Dr. Catherine Ledabrand, a hospitalist from Brookings Health System. Welcome, and thank you so much for joining us this evening. I called in a favor for both of you at last minute, so I appreciate you coming in. So, Dr. Malmberg, could you share a little bit about yourself and your practice here in Brookings?
Well, this is actually, I think, my third career, but I've been a doctor now since 2004. Did my residency out in Wyoming and came back to South Dakota. I've been in South Dakota starting in 1983. But I came back here, practiced in Malmberg for about 7 years, and I've been in Brookings for 10 years as a family practice doc, doing a little bit of hospital, but mostly outpatient.
All right, and we had an office across from each other, and I would always often listen to you quiz the med students, so I know you're going to be perfect for this.
Uh-oh.
All right, Dr. Ledabrand, tell about your background and specialty.
So, yeah, I'm originally from Lincoln, Nebraska. I actually did grad school and in parasites, and then went back to my initial interest in medicine, and I've been an internal medicine doc since I finished residency in Nebraska around 1999, and I've been practiced in Watertown as a general internist, both inpatient and outpatient. And since 2014, I became a hospitalist, did hospital medicine, and for the last 7 years, I've been down here in Brookings at the hospital here.
And the last 3, we've been working together.
Yes.
All right. Well, before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about any medical topic. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible, given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous, and no information is saved. Viewers can leave their name, email, or phone number to be entered into our drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. A winner will be drawn and announced at the end of this program. Well, let's get to some viewer questions. We already have several waiting for us. So let's start with this one. What is the difference between a hospitalist and a PCP, considering I have one of each?
Well, since one of I start because most of the people are going to start by seeing a PCP first. At least we hope so. And so primary care provider, or PCP, is your doctor that you would see on a regular basis on the outside. Your primary care physician can handle most of your medical problems, certainly the ones that you need to see on an outpatient basis. And then when we can't answer the question, then we either send you to a specialist, or if you're sick enough, then we send you over to the hospital, and I hand off to Dr. Ledabrand.
Yeah, the hospitalist, we take care of patients in the hospital, kind of what it sounds like, and that starts in the ER or sometimes from the clinic, and we are the primary kind of driver for all the stuff that gets done in the hospital, from the admission to the treatments. We try to help coordinate it, but it's a big team approach with all of usually we're talking with therapists, we're talking with the nurses, often different specialists, both the ones we may have here in town and many phone calls often with specialists out of town too. So, and then we get to the point of the discharge. And I should say one of the most important things is communication with the PCP, and that's the joy here of working in Brookings, is that we have really a close relationship, and so I feel like it's much easier to have that transition be more seamless, and I really value that, having worked on the PCP side too. So
yes. And actually, I think that's going to be an upcoming episode where we're talking about what is a hospitalist, since it's a relatively new idea, kind of in the last, I would say, 15, 20 years, where it's really gotten popular, having a specific person that will see you in the hospital, and your primary care doctor isn't coming over and seeing patients in the hospital like they did when I first started practice.
And I know from personal, it was to the point where to try to take medicine has gotten so complex and so fast moving, and to try to take care of hospital patients when you're over at the clinic, I would sometimes find myself having to cancel my clinic with no warning to go over and take care of a sick hospital. So now we've almost had to specialize, and there's many, and now there's even pediatric hospitalists, obstetric hospitalists, plus the doctors then are getting maybe a better work-life balance too. So
yeah, even surgeon hospitalists. Everything I was going to say is that one of the big advantages to having the hospitalist is that there's somebody there literally around the clock that can answer the questions, and certainly I think with the hospitalist system, and I've been in both. I practiced in Mowbridge, where it was where I was the hospitalist, and there wasn't going to be a hospitalist ever. But the advantage here is that Dr. Ledabrand is in the hospital and able to answer the questions, able to order a test. As soon as the test comes back, take care of it. Patients spend less time in the hospital. I know people have been upset when they go in and say, well, why am I not seeing my doctor? And the answer is because you'll get faster care, you'll get better care, not because that the hospitalist is the better doctor, but because the hospitalist is the better doctor for this situation.
That undivided attention that they can give, because it's not split between clinic duties and hospital duties.
Right.
So yeah, I think the workload has just gotten to the point where you do need to have it split between those two specialties. So excellent. But hopefully our viewers will tune in and we'll elaborate on that for an entire hour next.
So you're going to get called back, huh?
I'm sure you'll get called. All right. Well, back to more viewer questions. What could be causing frequent headaches, and how are they treated effectively? So lots of reasons for headaches. Dr. Ledabrand, what could possibly be?
Yeah, when they say frequent headaches, I think of a few things. One would be a common one that people don't often realize is rebound headaches. Certain drugs, if you are accustomed to taking them and then you don't take them, often you can get a headache without it. Often happens with Excedrin is one of the biggest drivers, I think. Caffeine withdrawal headaches are another. A biggie is sleep apnea, especially where you aren't breathing at night, not exhaling your carbon dioxide. That puts stress, and many people will have morning headaches with that, or daytime headaches and fatigue. So I'm sure you've seen some other ones too.
Right, and certainly those are some of the bigger ones that we see. We see tension headaches a lot of times when people come in and say, well, I'm having frequent headaches. I say, well, what's changed recently? And stress can be a big headache driver. Your brain is trying to follow your body, and your body's, if you're stressed, you may have more headaches. Anxiety, depression, several of those types of things. people think of some of the other ones, migraine headaches, cluster headaches. Sometimes migraines can happen frequently, and a lot of times that you need to be looking for what's changed that's driving that to happen. Cluster headaches are a lot less common than people think they are, and certainly if you have cluster headaches, you're going to know it because they are some of the most severe headaches around. So when you Google it, you may pick the wrong answer.
Yes, lots of different things. So, and this is where having a primary care physician that can help kind of tease out your symptoms, more of the headaches, where are they at, how are they, coming on, what have you been using to treat them or not, and kind of go from there. So lots of different things that could be causing it. So, and then once you know what's causing it, then the effective treatment will follow. Because if it's high blood pressure,
There we go.
all the Tylenol in the world or, Imitrex isn't going to help that. You need to bring your blood pressure down.
Right. And sometimes it's not even pills or meds, sometimes it's physical therapy, or if it's a pinched nerve in the neck that's causing maybe some injections.
Or treating that sleep apnea.
Treating the sleep apnea.
Excellent. Well, next question. What are some recommended medications for osteoporosis? So brittle bones and thinning of the bones.
Right. So the very first thing you need to do is make sure that you're getting good nutrition to make sure you have the supplies to keep building your bones back. People think of bones as being a stationary thing. You're constantly rebuilding your bones all the time, from birth all the way through death. And so if you don't have enough calcium in your diet, if you don't have enough vitamin D, if you don't have enough protein, your bones will suffer. So making sure you've got that. And then you start to look at medications which can help out with helping your body to realize it needs to build more bones. And I'll leave that over to Cathy.
So as far as there's been lots of medicines through the years, and some come and go, but right now the bisphosphonates, like the generic, or alendronate might be ring a bell. There's Reclast, and I can't remember what the generic name is on that, but that's an injectable one. And then there's another one called Prolia, which is often used. Often the Fosamax, the bisphosphonates, are the first choice, but it kind of depends too on your kidney function. Sometimes they have a potential to irritate the GI tract. So it's really a discussion with your doctor as far as what the best ones would be. And in addition to meds, though, we would want to talk about exercise. Weight-bearing exercise is huge. I think astronauts lose bone when they're in space, even for that short period of time. And so that is, and then there's certain drugs that, substances, a lot of people know that smoking causes lung cancer, but it can thin the bones too. Alcohol does that too, so looking at those risk factors.
Excellent. From an email, a viewer said they've been struggling with neck and shoulder pain and stiffness with headaches for the last 6 months. They've tried multiple chiropractors, massage, acupuncture. A few years ago, they did PT for some chronic neck pain and headaches. They wondered, should they be concerned there could be something else causing this? Is it just muscle tightness, or what other steps would you do? So, Dr. Malmberg, if you had a patient come in clinic and said 6 months, nothing's working.
Nothing's working, okay. One of the first things I would ask is what's been going on for the last year. You went this far without back pain and neck pain. What's changed? Are you more stressed? Is there something else? You've got a new job where you sit like this for 8 hours a day. Understanding the underlying causes can sometimes lead us to answers, although sometimes there isn't something specific, an underlying cause, and that's where you do have to start looking and say, is there something else going on?
Definitely.
I think sometimes at that point it might be reasonable to, if there hasn't been imaging, to image the neck, and sometimes that's an X-ray, sometimes it's a more involved MRI or a CT scan, but to look, because sometimes there's nerves that get pinched up in the neck. There's rare causes of headaches, and of course we used to just do X-rays all the time, but we really want to often, I can't remember what the length of time is that you want to give it time, at least 6 weeks.
Usually 6 weeks is kind of the standard.
I believe, so, but I would be thinking about that, trying to think. If it's mostly just neck, there's some, it doesn't sound to me like that would be something you'd expect going on in the brain, but it's definitely good to get a good evaluation. There are also pain specialists around. There's that can sometimes, maybe going to a dedicated pain specialist, sometimes there's injections that can be helpful. And they might also do more workup and help guide that. So.
All right, excellent. Another viewer is saying, is there a cure for their chronic fatigue syndrome or only ways to manage the symptoms? Chronic fatigue is difficult.
Tough one.
Yeah, especially we're seeing a lot more people with the kind of post-COVID fatigue is kind of a variant of chronic fatigue that I'm seeing more of, unfortunately.
And unfortunately, as with the post-COVID or the long COVID syndrome, there really aren't great answers. There isn't this simple cure. A lot of it is going to be management and doing things when you can, not overexerting yourself.
I believe exercise, even though you don't want to feel it, like thinking of it as a medication, like it's part of my treatment plan because it's going to help you feel better.
But not to the point of making things worse. It's kind of this moderate exercise, keep things moving, not getting sore, but enough to...
Yeah, being very careful not to overdo things, not to underdo them either. I often talk to my patients about the box that we live in, and we need to make sure we're pushing against the sides of the box so it doesn't shrink down on us, but we also don't want to be running against the sides of the box and injuring ourselves in the process.
It's a good way to think of it.
And chronic fatigue and fibromyalgia both have that situation where if you push too hard, then you pay for it the next day. If you don't push at all, then you pay for it the next year.
Yeah, true. All right. Well, Susan G. Komen is a foundation that provides resources to individuals affected by breast cancer. Carissa Smith is the Vice President of Education at Susan G. Komen. Smith talked with Prairie Doc about new and emerging technology for mammograms.
The Susan G. Komen Foundation invests in key research that improves outcomes of patients with breast cancer. The use of artificial intelligence in healthcare research has increased in recent years, including processing mammogram images. The AI used is built on algorithms and data sets.
Annual mammograms at some imaging clinics are now using artificial intelligence. It's a software that's going to analyze those digital mammogram images. It's built on algorithms and trained on data sets. So not all AI is the same. It depends on the algorithm, depends on the data set. We want to make sure that it's developed to reflect those diverse populations so it's accurate for all communities. So that's something to really consider. It's not all the same. However, there are some exciting studies that are showing that AI may find cancers a little earlier or in difficult to see images like images of dense breasts. Data is early, but we're excited to see where that goes.
By using AI, results may be processed quicker and more thoroughly, allowing for better patient outcomes.
Using AI, radiologists may be able to work faster. Most mammograms are read by 2 radiologists, and so AI can't really currently replace that perspective and experience. But again, they can work faster, prioritize better, maybe eliminate the need for that second reading.
Using AI is a win for patients, but is still in the early stages with additional research needed.
This is one aspect of data. There's so much potential for bringing multiple sets of data. So do you now bring in information about biomarkers? Do you bring in information about other risk factors? And then that all comes in and gives additional information with the screening mammogram.
Through further research, healthcare professionals will look to see if AI-assisted mammograms can better identify cancers.
AI is going to help us really analyze and clarify what the path forward is for patients.
Well, we got a little touch of AI about being used in practice there. Dr. Malmberg, have you seen much AI used in family practice, or is this still a very emerging?
Well, we are actually seeing a little bit coming in, and I use AI in my current practice. I have a friend called Freed who follows me into the room on my computer and listens to the visits, so I can spend more time actually talking to the patient and less time staring at my computer, and it then will track and put together some of the notes, keep track of everything that was said. Is it perfect? No. Well, of course, neither am I, but it has some difficulties, especially with my bad jokes, but it does help make my life a little bit better and allow me to spend more time focused on the patient, which is where I really want to be.
Excellent. Well, I think that was going to be a great show. Unfortunately, Mother Nature had other plans, so maybe next season we can try again. But let's get back to our viewer questions, because there is not a lack of those. So a viewer on Facebook says, what would be the best treatment options for their anxiety disorder? Dr. Ledabrand, what do you like to have with patients with anxiety?
Well, again, we keep coming back to exercise. That's a huge, helps so much with anxiety, a regular exercise program. You want to, well, first of all, you want to make sure there's not secondary reasons they're having anxiety. Sometimes they're actually on a medication. Some depression medicines actually can make people more anxious. Certain, again, hyperthyroid, if your thyroid's overactive, or even untreated sleep apnea is a big cause too. So you want to look for those types of things. But as far as treatments, I think some people may not be old enough to remember, but when I was in training, a lot of people would just automatically get Valium and get these benzodiazepines or sedatives. There were people who'd been on those for years. That's really not a good long-term treatment, or even it's a very short term if we use it at all, because of potential for side effects and dependence. So there's a lot of medications. If one does have severe anxiety, certain classes of drugs, the SSRIs, like you might have heard of Zoloft or sertraline or Lexapro or escitalopram, those would probably be the biggest go-tos for anxiety. Then there's other short-acting kind of as-needed ones. Instead of lorazepam, there's one called buspirone that is kind of a shorter-acting that doesn't tend to be as habit-forming, or I don't believe it's really habit-forming, but it really is kind of, and then I should say, in addition to exercise, the meditation, the Calm apps, being in nature, really trying to slow down. And there are things I think we all know we need to do, but actually doing them really does make a huge difference.
Yes. I always say working with a counselor is always a good thing.
Absolutely.
And sometimes finding the right counselor. Not everyone's the right fit. I've had people say, oh, I saw a counselor, it didn't work, or I didn't like them, or you just haven't found the right one then for you.
And definitely no one counselor, no one doctor is the right person for everyone. So finding the right counselor, I use the analogy, counselors are like coaches. Their job is to challenge you a little bit, make you think about how you're thinking, but to also get you to move in the right direction. Now, there is anxiety that is going to respond very well to counseling because people have underlying issues that they need to resolve. There's going to be anxiety. Anxiety isn't a single entity, and so there's going to be anxiety that isn't going to respond, that is going to need more of the medications and more of the the medical treatment. But it's worth trying the counseling, the exercise definitely, to help with that, because those are much more benign treatments. They're not going to cause more injury. And there are going to be people who are going to end up having to do more than just the SSRIs. We have people who we have to send on to the psychiatrist, who are going to get additional medications, sometimes even antipsychotics to help out with their anxiety. Fortunately, they are the minority, but they do exist.
All right. Well, another viewer said this year they've been waking up a lot at night and then having trouble going back to sleep. And they did put in the caveat, they are a 50-year-old female. So I'm thinking menopause would be at the top of my differential for that as a 47-year-old female.
Yes.
So
And I remember 50 now. I'm old enough to now
anymore.
remember it. So, yeah, and that's a tough one.
That's tough.
There's so many changes in the sleep. That disruption is really
between hot flashes and hormones.
And some people hormonal treatment can be very effective. Not everyone is a good candidate for that type of treatment. There's also some supplements of varying efficacy. I'm more on the outpatient side. You probably are more familiar, but I know there's some soy isoflavones and some things like that. But also, there's many other things that occur during that time that could also be affecting the sleep, like the sleep apnea. I can know from personal experience that was one of my issues. I attributed it all to menopause, and a lot of it was sleep apnea. And then sometimes depression and anxiety.
Right.
And
then, of course, one of the questions I would ask if the person came in to see me was, well, what are you doing when you wake up, and what wakes you up in the middle of the night, and then what do you do when you decide to try to go back to sleep? A lot of us sabotage ourselves. You wake up and you go, oh shoot, did I do this or did I do that? And you get stuck thinking about the wrong thing. Or
you grab your phone and start scrolling.
Don't. You know that you're hooked on Candy Crush when you have to play one more game on the way back from the bathroom. All those are they're traps to keep you awake at night, and so avoiding those. There are sometimes things that you can do before you go to sleep, and you can certainly talk to your doctor about medications to help get you to not wake up as much in the middle of the night. But if you have to go to the bathroom, really, we'd prefer that you not.
We want you to wake up.
We'd want you to wake up.
And then just good sleep hygiene, not exercising too close to bedtime. Many people sleep better in a cooler room, cooler temperature. So
put the phone down turn off the TV at least a half an hour before you go to bed. Get the TV out of the bedroom. The people that go, well, what happens when you wake up in the middle of the night? I turn on the TV. It's like you're toast.
Yep, that light is going to mess with your circadian rhythm and your sleep cycle. So, all right. Well, another viewer said their husband was recently diagnosed with an overactive thyroid, but he is hesitant to take medications. What would be potential consequences if he left this untreated and didn't take anything?
Oh boy. Well, I like to think of the thyroid as some kind of a idle position, and if you have your idle speed too high on your car, things don't work well. Hyperthyroidism can lead to heart problems, heart rhythm issues, high blood pressure. It can lead to anxiety. People say, we say it can lead to weight loss. Some people go, well, in that case, sign me up. But when doctors used to do that for people to help them lose weight, people end up dying early from this. So it is not a benign.
The heart has to work harder too. If it's overactive. I have had to put several people in the hospital with the heart rhythm problems from the overactive thyroid. Diarrhea is a big. Something we see quite a bit, and then the hot flashes and even anger outbursts and things like that. So I think it even can contribute to osteoporosis too.
Okay.
Right.
So.
All right. A viewer wants to know, what are some of the best ways to prevent and treat seasonal allergies? I'm having so much trouble this year, and my normal over-the-counter medication is not helping. Ooh.
It's a bad year. It really is, and I've had a lot of people coming in with problems with the allergies. Prevent is very, very difficult because unless you can go up on the space station and get away from all the allergens, and then you probably would have some plastic allergen that would set you off. It's very hard to prevent allergies. You can certainly minimize your contact with some of them. If you have a lot of outdoor allergies, running the cooling system or heating system in your house with a good HEPA filter and not having the windows open long periods of time can make somewhat of a difference, but most of the time you're going to have to treat them.
Yeah. Yeah, I think some people, also try to shower sometimes, make sure you're washing your pillowcase. That a lot of people get that at night. But as far as the treatments, there's the over-the-counter antihistamines. I believe when I've heard it, I don't know if that's still true in the outpatient world, but the nasal steroid inhalers may be the first choice for, actually, as far as efficacy for the runny nose and even some of the eye symptoms. Then there's some eye drops. I'd be curious what types of allergy symptoms. Is it runny nose? Right. Is it the itchy eyes? Is it wheezing or asthma? There might, sometimes that'll trigger asthma too. There's those meds, the steroids, there's Singular, I believe, that's a prescription, but especially for the runny nose that doesn't respond. And then some people might, and then having personally dealt with severe ragweed allergy, there is, if they're really difficult to manage, there's great specialists, allergy specialists, and even allergy shots that can really decrease it as long term.
Kind of the final thing that some people have had to use, I've had to use it once myself, and that was you have to go to your doctor for this, but getting a short course of steroids to just kind of calm your whole system down. Now, these are not benign medications. They do a lot of different things. It's like a bomb that you're throwing into your body, but it really will shut down the allergies fairly well, but only for a limited amount of time. But definitely the allergy shots is a big player. And also looking maybe if you know you have a lot of problems, figuring out which allergies you do have, and seeing if maybe there are some that you do have control over. Like, okay, yes, I get bad at this time of year, but I didn't realize I also have a dog allergy, and I have a dog. I had one family who's...
I should say I didn't realize, my nose was stuffy for about 22 years while I had my cats, and then when they died at 22, then I was suddenly much clearer. I could breathe a lot better. So I missed them, but it did help my congestion.
Yes.
And it can be, allergies can be more than one thing. I mean, you can get, as you say, asthma, nasal allergies. I had one poor boy that had horrible eczema because of his allergies. And his parents said, "Don't worry, we're going to move the dog outside when it gets warmer."
Yeah, only so much you can do. Well.
Right.
The South Dakota Simulation in Motion, or SIM program, is an innovative healthcare initiative aimed at improving access to quality emergency medical care and training in rural and underserved areas in South Dakota. The South Dakota Department of Health contracts with Avera Health, Sanford Health, and Monument Health to provide these training opportunities. Daryl Michael, the simulation coordinator for the Avera CareFlight mobile simulation team, gives the Prairie Doc detailed insights into what the mobile sim lab provides.
The SIM program came about as a process through utilizing grant funding from the Helmsley Charitable Trust, and I believe that was about 2010 when the developments started to come together. I think it was because there was a recognized need, especially in rural, smaller critical access hospitals and EMS agencies, to get better quality training that wasn't readily available without a significant amount of travel.
Bringing the training to them is a great benefit, as they can train in their facility with their equipment on their time, so it greatly benefits the rural facilities.
I think as far as the education side of things, it's very difficult for them to get in-person education because of the distance that they have to travel. They have very limited staffs, so trying to get a weekend off to go to a conference or go attend a class in Sioux Falls or Rapid City or wherever is challenging for them, not only time-wise but cost-wise.
There are 3 semi-trucks that travel across South Dakota, one each operated by Avera Health, Sanford Health, and Monument Health. Each has a designated area where they provide training.
We probably don't have enough time to list all of them, but the main focuses that we do are kind of things that are life threats in the community. So we do a lot of airway classes, airway management classes. We do a lot of cardiac and like managing someone with a cardiac event. And we do an awfully lot of OB and labor and delivery type of simulations, especially out in the critical access hospitals, because most of them don't offer delivery services anymore.
According to Michael, the ultimate goal of the program is to train as many people in the state and region to give them confidence and the opportunity to learn these important skills.
And I think that just gives them a great deal of confidence to know that they've seen this before, and now when they have it in a real patient, they will recognize those symptoms and know the right path to take.
Well, how important is this life-saving training for health providers in rural areas? So have either of you had a chance to do the sim? I did when I was in Tyndall, so I had an opportunity to use it.
They had it when I was in Mobridge, but I don't think we ever got it up there, at least not for me. But I have seen some great things from it, and it's great because we are having so much trouble with getting training and keeping enough help first responders available in the rural areas.
Yeah, and this is a very, even though it's a mannequin, it's still very realistic training, and you never want your first time delivering a baby to be in an ambulance on the way to a hospital, as if you're in Tyndall going to Yankton or Mobridge, that would not be fun. So this would be a good way for those people, especially a lot of our EMTs in rural areas are volunteers. This is not their day job.
Yeah.
So anytime they can get additional hands-on training in a setting where they can be observed and in as close to the real life setting as they can, I think is invaluable for this.
Right. And I'm so thankful that the Helmsley Foundation put out, because these are not inexpensive toys.
No, and the mannequins there are amazing. Their pupils will react. You can intubate them. There's a microphone so the patient can talk to you and give you the history of what's going on. You can actually start the IV. You can intubate them. You can put in a chest tube. You can put in a catheter, a Foley catheter in the bladder. I mean, these are anatomically correct and working models. So it's as close to the real thing as you can get. And actually, I went back to my medical school and saw their sim lab. They've gotten the next generation of mannequins that the skin actually feels real, and they painted on freckles, and they actually cast the face off of a real person. So these look like real people, not the CPR dummies that we were used to training on. So it really adds another layer of realism to it with these, and you can really get that really good training for students before they have to deal with a real patient, which I think is wonderful.
Yeah.
And you never want their first procedure to be on, practicing on your family.
It seems like it'd be something we should have, like in the hospital with nursing trainees and docs, and it'd be wonderful to have.
I know the nursing students here have access to some of those simulators. In the medical schools, they're now using the simulators a lot. We've gotten away from using pigs or whatever we have used in the labs. So a lot of it is going to simulators. The really nice thing is that you can do a lot more with them, and especially for the folks out in the rural areas, they can do a lot more with them than they're going to be able to do with anything else that we would bring. So I'm pretty happy about it.
All right. Well, kind of following up on our allergy question, viewer wants to know how they can best manage their asthma and avoid triggers. So a couple different variants of asthma, exercise-induced asthma, then I would say, pre-medicating before exercise is always a good thing with your inhaler.
Yeah, and don't avoid the exercise. Oh, look, I have exercise-induced asthma. Let me just sit at home and change the channels. That's not a good idea either. But exercise-induced asthma, definitely pre-medicating beforehand. And if you're going to be exercising a lot, then talking to your doctor about even using a long-term medication to help control things. Because with asthma, one of the big things we want to do is not just keep using rescue medication. If you're constantly doing that, you're allowing inflammation to build up in your airways, and pretty soon you'll have some permanence to the damage. And that's really one of those things that I try to emphasize with people, because they go, but this works, and it works really quick and really well. The fast solution isn't always the right answer. But with knowing what your triggers are is probably the number one thing I would say with asthma, and avoiding problems with it. What sets you off? What time of year is it worse? What are your allergies associated with it? And allergies can be your best friend.
And things like also reflux, acid reflux, a biggie. And that too, there's people that have years of acid reflux that don't necessarily get it treated, and that can damage the lungs too, as can the asthma it triggers. And then I believe like some postnasal drip, that's another trigger.
Yes, and Singular can be used for both allergies and asthma. So some of these medications kind of do double duty with that. All right, well, viewer wants to know, what are the potential causes of their ongoing dizziness and how can it be addressed? They already checked their blood pressure, that's normal, and it started last week and happens a few times a day.
Boy, I wish I had my student here. I could have her give the little talk I gave her.
Yes.
One of the first things you need to say is, what do you mean by dizzy? Are you lightheaded? Are you off balance? Is the room spinning? Or do you mean something else completely by dizziness? Because those are very different things, and there are very different causes for them. So maybe I'll cheat and take the easy one, and that's the room is spinning. And vertigo, if it's happening and it's multiple times a day and you're not feeling sick otherwise, most likely is benign positional vertigo. We think this is caused, nobody's been able to prove it, but we think this is caused by little things called otoliths that get into the semicircular canals in your ear, the gyroscopes basically that tell you when you're turning. And when they get in there, it gives you a false sense that you're turning. Physical therapy, or sometimes doctors can give you maneuvers that will help out with that. I understand there's even a YouTube maneuver that can show you, that you can try on your own. But that's the way that you can help with your vertigo. If it's something else, then you need to do something different. So I'll throw the hardball at poor Cathy.
A lot of people get admitted to the hospital for dizziness, and a lot of people in the hospital may say they're dizzy, and sometimes it's things we do to them, and other times it's their processes. But the lightheadedness one is a difficult one. That just, or it often can be, what it kind of boils down to is often when you feel lightheaded, you aren't getting enough blood to your brain, and that makes you feel like you're going to faint. Sometimes that's because you're dehydrated, and that happens often when people are on some blood pressure medicines. I see a lot more dizzy people in the summer. They're on water pills and blood pressure medicines, and they might get really dehydrated, and then suddenly what was working in the winter when they were drinking lots of fluid and not out in the heat is a little too much for them. So that's one. Sometimes the blood isn't getting to your brain because maybe your heart is just beating ineffectively, too rapidly, and it's not pumping very well. Or it could be too slow too. Sometimes there's certain reflexes where people may cough and get dizzy and even faint because of pressing on their carotid, this area where the nerves are in the carotid artery, and that'll make the heart rate go down, and they'll feel faint. Sometimes it's because they've been bleeding and didn't know it, and they're anemic. So and then so that's one broad area.
All right.
Or they're anxious.
Yeah, anxiety is another cause of dizziness. Sometimes people, if there's a spinning type of thing, vertigo, occasionally strokes will cause dizziness, but we can often do a lot of testing. We often will check the heart rhythm, check the blood count, check the blood pressure, not just when you're sitting, but when you're standing. watch. Yeah. So
Or medication side effects. That's another thing
Yeah.
we want to
Oh, yes.
not make sure that we rule that out. So, well, we have 8 questions in 8 minutes, so lightning
Okay.
round.
All right.
All right. What is the best treatment option for their chronic pain, fibromyalgia? They're not having any luck making it better. So we touched
that's
on
a
this a
tough
little
one.
bit. Yeah, that's not a 1 minute.
Yeah.
Now, exercise again is the thing that the rheumatologists will tell people the most to work on. There are some medications that are not as sedating. Some of the things like amitriptyline, topiramate. You should try to be careful with the opiates because they're a really slippery slope when you start going down that direction.
All right.
Yeah.
Well, we'll keep going here. Are digital rectal exams to check the prostate part of a typical wellness exam for men?
Used to be.
When I trained,
My first was my first exam in the military at age 21. But we don't do them as much anymore, primarily because they're not very sensitive for prostate problems. They're also not they are fairly specific, but they're not as sensitive for prostate problems. You can have a lot of prostate cancer that you will not feel on it. We do them still for when I'm looking, saying, well, how big is the prostate? And looking for other things such as blood in the stool, if I need to find a quick answer on that. But no, they're not something that I necessarily do on every single male exam. And I have not had one now in a few years, and I'm not sorry.
You know, the thing about that, the prostate's kind of a ball here, and if you're thinking, with the digital rectal exam, you could only feel one part of the ball. Can you tell me there's not a cancer here or here or under there? It's such a limited area you can reach that the utility of it really, as a screening exam, you could give yourself a lot of false sense of security saying, nope, it feels fine, when you don't know what's happening on this other side you can't physically reach.
Right.
Yeah.
So, all right. A caller asks, what's the difference between an MD and a DO? I will take that one as the token DO. So, MD, medical doctor. DO is doctor of osteopathic medicine. So, they are equivalent titles. It's just the med school that you went to. So, there are MD med schools, there are DO med schools. Traditionally, DOs are more primary care, but DOs can be any specialty. I believe this current Surgeon General is a DO. So DOs, it started in the 1800s with Dr. Andrew Taylor Still, who is a MD who really liked orthopedics and liked bones and liked setting bones. And at that time, you could open your own med school, and he decided that he was going to open his own med school, but wanted to focus on joints and how they are, and found that if joints are out of alignment, that it could affect someone's health. Because if you're hunched over like this, it's hard to take a deep breath. Well, if I can help you straighten up and stand up straight, that can improve your breathing. And so found that through certain osteopathic manipulation techniques, kind of similar to, there's some overlap between massage and chiropractor and physical therapy. There's all kind of overlap in some of our techniques that all DO students are taught in their training. Now, do all DOs do this? No. Have I done OMT outside of my family? Not in a very long time, but it is something that we're all taught, although, kind of once you get out of med school, we're taking the same boards. The residency programs have all combined. I was taking residency side by side with the MDs. Really, only thing you could tell is the difference in my initials on my diploma or my ID badge. But other than that, we're the same.
I second that.
Yeah.
Very much the same. And it was really nice. I know you've helped out a couple times with headaches and things like
Yes.
that, because I went through a dual boarded residency program, and so learned to do the suboccipital release, and they tried to show me some of the other DO techniques, and I failed miserably.
Yeah, so I would say a DO is an MD with 500 additional hours of musculoskeletal training and a couple of cool tricks up our sleeve that, if we haven't forgotten how to use them by the time we get out in practice, is really helpful to have. But really, you're in good hands with either physician. Traditionally, DOs, we talk about very holistic patient-centered care, but honestly, I can't say that you guys are any different than I when it comes to the amount that you want to take care of your patients. That you guys are very holistic, patient-centered care as well. So I don't think DOs can claim that as our own quite like we maybe initially did back in the 1800s. But definitely a very interesting question, and I think we should have a show on that, talking about it.
There we go.
It's got an interesting history, but I think as time has gone along, it's less and less. So in our last minute here, a viewer wants to know what other than physical therapy could be the treatment for uterine prolapse. So this will be our last question.
All right.
Other than physical therapy. So the pessary device that kind of goes, I guess I haven't seen too many of them. But
they go in the vagina, they fit up.
Push everything up.
I've actually had a couple patients that I've had with pessaries, and there are different styles of them. We have one doctor at our clinic in Brookings that is very interested in them and does a fitting of them. And they can often prolong and keep women from having to go to the next step, which is generally surgery.
Yes. So definitely, yes, the pessary is a good option if you're looking for non-surgical or if you want to be a good surgical candidate. With that, it is something where generally people do go to the doctor and they have that replaced. It's taken out, cleaned, and then replaced in the clinic. So yeah, I think most people do that.
And I've had some patients who've had those for years that, and very happy with it, and like.
And a lot of my patients with them have learned to manage them as long as they are fairly healthy. Otherwise, they can manage them themselves. They can take them out. They can clean them. They can put them back in. But they have to have been taught properly to do that.
Yep, and sized properly. So that's something that your OBGYN would do to make sure that they fit properly for you, so they're not causing any more harm rather than good. So, well. Our winner tonight is Anne. A book will be sent to you shortly. We'll be back after this.
Grab a copy of your local newspaper or read online the Prairie Doc Perspective, a weekly health and medical column. Head to prairiedoc.org to access all archived columns today.
Thank you to our guests, Dr. Malmberg and Dr. Ledabrand, for volunteering their time to answer all of your medical questions. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on South Dakota Public Broadcasting Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Your knees and hips are your largest joints. They support your body's weight and must work in close coordination to provide the mobility most people take for granted. Troubleshooting Guide to Hip and Knee Pain, next time on Call with the Prairie Doc.
My name is Carter Home, and I serve on the board of directors of the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,